very learned, very experienced presenters for different topics. So today we are very honored to have Dr. Khurram Azam Mirza, who is a senior consultant veterinary surgeon working currently at Hameed Lateef Hospital, but previously he's worked in the United Kingdom for many years, especially in Ireland, and then he came back to Pakistan and joined LRBP Hospital as a consultant veterinary surgeon, and has trained dozens of trainees in veterinary surgery and also the sacred surgery. He is a very accomplished surgeon, very experienced. There was a time when his fame was that he used to finish the phaco from upside to the patient rising up from the table just in 2.5 to 3 minutes. ये on record है और ये live performance थी, ये नहीं कि कोई edited video है या कुछ और है, ऐसा कुछ नहीं था. माशाल्लाह इतना इनका अल्लाह ताला ने मुश्किल दिया था. उसके बाद फिर उन्होंने रिफ्रैक्टिव सर्जरी की भी फेलोशिप की, फिर विट्रो रेटिनल की फेलोशिप की और फाइनली इन्होंने विट्रो रेटिना को अपना सब स्पेशलिटी बनाया और उसी की बहुत अच्छी प्रैक्टिस करा. एक और जो काम इन्होंने बड़ा यूनिक किया है पाकिस्तान में और ख़ासतौर पर लाहौर में, ROP की स्क्रीनिंग इन्होंने स्टार्ट की. क्योंकि हमीद लतीफ़ में प्रैक्टिस करते थे तो वहाँ पे गायनी और ऑब्स्टेट्रिक्स का बहुत स्ट्रॉन्ग सिस्टम है और कोई 100 से ज़्यादा गायनोलॉजिस्ट और ऑब्स्टेट्रिशियन वहाँ काम करते हैं. तो बेतहाशा वहाँ डिलीवरीज होती हैं और जो प्री टर्म बेबीज़ होते हैं, लो बर्थ वेट बेबीज़ होते हैं, उनको नर्सरी में रखा जाता है. फिर इनको कॉल आती है, ये जाके बच्चों को देखते हैं. एंड ही हैज़ मोर देन ऑलमोस्ट 1000 babies in his record, in his series, whom he has examined, treated, and is managing them and on their follow-ups. So it's a great service that he started in Pakistan. कोई नहीं उससे पहले कर रहा था. अब तो खैर इंटरनेशनल भी सिस्टम पाकिस्तान का डेवलप हो गया है, प्रो पैरा ग्रुप बन गया है, सोसाइटी भी उसको पैटर्नाइज कर रही है और अभी रिसेंटली उसकी एक 2 दिन की कॉन्फ्रेंस भी हुई है अप्रैल की 1st वीक में. तो एक और जो बहुत बड़ा फीचर है हमारा कॉमन, वो ये कि मैं और खुर्रम जो है हम क्लास फेलोज हैं किंग एडवर्ड के इकट्ठे, नॉट ओनली क्लास फेलोज बट ऑल्सो बैच फेलोज. इनका रोल नंबर 162 होता था, मेरा 164 होता था और बीच में एक लीड होता था जिसका 163 होता था. वो प्रॉपर्टी का कारोबार कर रहा है, वो डिफरेंट लाइन्स चला गया. वी आर अबाउट 8 or 9 people who opted ophthalmology from the same class. And majority of them अल्लाह के फजल करम से सारे सीनियर पोजीशंस में हैं. अली अदम मरूम भी हमारे क्लास वालों थे जिनकी बेचारों की डेथ हो गई. जाहिद कमाल हमारे क्लास वालों हैं. उसके अलावा इंग्लैंड में 2-3 हैं, एक नील सिद्धू है बुले वाला में, वो हमारा क्लास वाला. इस तरह से, और उसकी मेन वजह ये थी कि जो हमारे टीचर थे वो प्रोफेसर जलील वाला थे और वो इतना अच्छा पढ़ाते थे कि वो उनके पढ़ाने से हम इंस्पायर होकर इस फील्ड की तरफ निकल गए. तो फॉर्मल प्रोसीडिंग स्टार्ट करने के लिए तिलावत के लिए मैं डॉक्टर उज़ैर को कहूँगा कि वो आएँ और तिलावत के कलाम में बात करें और उसके बाद हम प्रेजेंटेशन स्टार्ट करें.
Looking at the audience, I think half the audience is going to get very bored because they're quite senior and they know all these things. I originally prepared a relatively basic talk, but there are some points that should be of interest to everyone. So we'll just go quickly on this because it's a long presentation, and we start with the principles of these lasers. Basic principle is the laser produces this therapeutic effect by heat, and that heat is generated by vibrating molecules of light energy how it affects the tissue. And so there are certain tissues in the eye or in the retinal area which are absorbers of, or very good absorbers of the laser light. And those are like melanin is the best one, and hemoglobin and xanthophyll are the other ones. We just stay at the most important points. And most important point is here that while we are doing laser, especially when we are starting these things, you should realize that the size matters. But over here, smaller is the strongest one, because if we compare a 100 micron size with half the size, the power is condensed in that half area, and it doesn't just double, it quadruples, because a 50 micron spot size will have the area about 1/4 of 100 micron. So that's why in a smaller size one, the power irradiance is much increased. So we should know that. And then the basic thing is the light is absorbed, and then further there is in that tissue in the choroidal temperature increases, and which causes two things. One is the immediate inflammation, and which later on causes the therapeutic effect and sometimes scarring. How is this effect taking place over there? It's basically the rise of temperature. The temperature rise to produce some therapeutic effect has to be about 10 to 20 degrees from the baseline, and if it's over 10 to 20 degrees, then we'll see that the overlying retina is specified. And that is when we are talking about flat retina. And but when we are dealing with macular edema, that's why we have to be very, very careful, because in macular edema, the retina will not be easily opacified because there is a lot of fluid there. And we have to be careful. We should do our test run on the side in a flat retina so that we see a very light pale burn with whichever we want to have. And then the same amount we should apply on the macular area, within the area of that macular edema, and we should not just keep on increasing the power to get that white reaction, because then it will be overheated. And again, pigmentation has to be kept in mind, because melanin, as we know, is the best absorber, and if we use the same amount of power there, we can cause a gold. And how do we reduce the burn intensity and the effects of that? We have a few things where we can just reduce the power. That's one. Or we can just reduce the duration of the laser, because the same power, if it is applied in less time, then the effect will be reduced. Or we increase the spot size. By doing that, again, just saw from 50 to 100 spot size, the irradiance is 1/4. Now, what are the different types of lasers which are available? In the past, we started with xenon arc and other things were there, but I'm not going that far back. But clinically, which were very good, this was krypton red. Now, these are bigger wavelengths, krypton red and the infrared one. So 647 and 810. The bigger wavelengths, they are absorbed by deeper tissues, deep in the chorioretinal area. So they are quite safe for the retina itself. Whereas argon green, it's not so deep, so it affects retina as well as deeper tissues. Blue. Blue use retinal laser started with blue first, but blue is absorbed beautifully by xanthophyll, so it can run havoc with the macula, so it's never to be used in the center. That's why they changed it to then blue-green, and about 15-20 years ago, blue-green were the lasers, and again we had to be careful in the macular area. Eventually, this 532 green came up, and it's relatively safer in the macular area, relatively, not absolutely. So this is the one which is most commonly used now. We'll just look at some properties of each and every one of them so that we know where the others are being used. So what the dye laser, as you see, this is yellow laser. So we have heard about yellow laser a lot. And so some advantages are that it has negligible absorption in the macular gland, so it's very safe for the macula. It doesn't scatter in the eye at all, so it's quite targeted. And it causes very little, that's the reason it causes very little retinal phototoxicity. And while doing the laser itself, you have very good tissue visibility. So if you're doing continuous shots, it's much easier with yellow as compared to green. Even it's possible with green, but it's much better with yellow one. And it's quite less discomforting for the patient. I won't say it's quite comfortable for the patient. You always feel a little bit, but it's much better than the average ones that we are using. So these are the advantages, and it's very good for vascular regions because it is absorbed by the glue. Now, this is the one we are using. It shares a lot of common things of the yellow laser. So that's why, and it's easier to produce and easily available, less expensive as compared to yellow ones. So that's why there is more commonly used. So it's almost the same but not as good as yellow laser. Then the semiconductor ones. These are infrared radiations and these again can so advantages are that it's very small size. It's a wonderful tool for ROP treatments because for ROP treatments you have to do very fluid and heavy kind of laser, so this is quite gentle for those. And the distracting light inside the eye is spent much less by the patient. So if we have to do top-up laser on an ROP child or maybe without GA, this is the one to go for because the other one is quite distracting for them. So the only disadvantage is that the reaction comes very slowly. So if you just do 10 shots and you're at the 10th and then you see those the reaction coming up. So once you have practice for that, it's easier to use. It's just for the beginners. Now, this is our usual YAG laser, implanted YAG laser. It has nothing to do with retinal, although it's made for anterior segment membranes, but we use it in retina. And so the so-called thing with YAG hyalotomy, which I call hyalotomy because this term has been going on for a long time, and since the day of OCTs and the OCTs are getting better now, we saw so many of them. And we started doing OCTs on them, and 80% of the time we were quite sure that blood was under the ILM, and what we had lasered and opened up. If we did OCT immediately after that, it was the ILM that we opened up. So there may be some alert hemorrhages, but there are certainly some ILM hemorrhages as well over there. Paracellular kind of hemorrhage, it's usually sub-ILM. So we have to use very high power in those. And we tried all the lenses, but the only lens which works is the central lens of the triple mirror one, and the others will not focus this for you. And so we choose the bulky part, but as dependent as possible, because this is a high power laser and it causes a hole in that ILM. We don't want to do it in a very shallow area because we form will rupture the retina there. So other than these hemorrhages, it is used in clearing up mid-vitreous and anterior vitreous membranes. Sometimes there's very thick cell-laden fibrotic PVD coming in the center. Happens a lot in post-uveitic patients, and so we use that a lot, and because to form a hole, it takes a long time, a lot of energy, but you form a hole in there, and so the vision improves a lot. Erbium, it's actually erbium YAG laser. Erbium, it's not being used now a lot, but basically it came, I remember it came came in mid-90s as erbium diagonal phaco. So that was the first phaco, and it came by the name of Elagio. And we used that. I was doing my refractive fellowship in those days, and we used this laser to do cataracts, but it would do only very soft cataracts. And for the lens, we were using rollable IOL, so the incision remained actually only around 1 millimeter in the whole procedure. But as it couldn't do anything, even in the medium range, so it was abandoned. Then it's used in the cutters, vitrectomy cutters. So vitreous is opaque to this thing, and it can cut the vitreous. And this is the one which has been used, although blades and threads and other things have been used as well. But this tool has been the best one to create shunts for the CRBO patients, so that we develop a chorioretinal circulation to relieve that blockage. So this is that laser. So what are the different patterns? So you all know that there's a focal laser which is used for microrealism, APRs and CSRs, grid resin laser which can be mini grid or modified one, and scatter laser, sectorial, PRP. Confluent lasers are often used in CMV, hemangiomas, and some lesions where we want to actually burn the thing and finish it off. Almost confluent in ROP, and then virages of all kinds, the brave or 360. Then in Coach disease, where we have dendritic vessels, it has to be quite confluent. And if you want to burn a small retinoblastoma, even confluent lasers are used. So these were the different kind of lasers that we do. So coming to each one of them, some important things. So in macular edema, obviously, macular edema can be because of microaneurysms, which are easily distinguishable. So we do focal on them. And if they are not seen easily and you have macular edema, then we do a grid. And so amount of grids have reduced over the last 10 years, I would say, slowly and gradually because of these injections and GPTs. And rightly so, because you don't have to do lasers. But I think with time we'll see, as we come into micropulse, that they'll be increasing again. But so far that's what's happening. The technique of focal, obviously we have to do it directly to the microaneurysm if we see the microaneurysm. And if we can't see the microaneurysm and we have those succinate exudates and all that, then we have to stay in the middle of those exudates and do that area as well. Usually with the spot, depending on how far away is it from the center, 50 to 100 microns in addition of 50 seconds. What we need is that area to be gently turning white. Or keep an eye on the microaneurysm becomes from bright red to almost black. So it darkens, so that's where you achieve your treatment. And you have to be very careful. If you are within 300 microns of the fovea, then the duration should be reduced. Reducing from 100 to 50 milliseconds is a safer option, and obviously the size of it as well. Most important thing in grids is, or any focal laser, both of them, that we have to be patient. We have to do a good session. Once we have done a good laser, and we know that it's there, we should wait 3 to 4 months, because that's how long it takes usually for the fluid to dissolve, and we should not retreating the macula over and over again. So some examples here, and I mean this is very simple. Right in the center you can see microaneurysms, so you can just laser them, and easily this will be focal laser here, as opposed to some modified grid in this area where you can't see it. We still call it focal. Similarly, in this, you can see succinate rings, and within those rings, do a little bit of laser, it will go away. Now, the important thing here is what to do with these things. Again, it's been 3 months. You can see that the quality of exudate is different. If those exudates are still there, but they are sharp, and so then we don't call them active exudates. We just call them edema residue or residual exudate, because that's inactive. That's and it's away from the center, it will probably stay that way or take much longer to go away. So there's no need to treat these. And of course, later on, if you need to do FFA and see what's going on. But so these are edema residues, and these can be observed. Again, for something like this, now, some of these, this is again straightforward. Just do these and they'll go away. No need for anything else. A lot of this can be done. Something as close to this as well can be done if we try laser around here, but something like that, again, you don't have to worry too much about it because we have injections now. So most of the basically where there's such close to phobia leakage, we should start with anti-VEGF anyway, and later on, one this area or maybe the meanwhile. But this should be treated originally with anti-VEGF, and whatever is remaining, and then it can be justified by doing the laser.
Shouldn't we all know that this is a phobia revascular zone. Still we see exudates exactly like phobia or very near to that. What is usually the source of those exudates? Because the blood vessels are far away from it.
Yeah, the usual blood vessels are far away, but in the macular edema and diabetic areas, it's often you will see, actually when you see a microaneurysm around here, that means the blood vessels are there. So that's the edge of the blood, because the avascular zone is actually only here. This whole thing is only here. This area is vascularized, because FAS is only this. So there will be a lot of blood vessels there, but often the edema which comes here is from behind, because, and that's, we come to those, I think it's the next. How does grit work? Grit works because when we apply laser there, it goes to the deeper layers and it causes a reaction there. The therapeutic reaction increases the oxygenation of that area, because you form a reaction there, you get oxygenation from choroid. That is the purpose of grit. When you get oxygenation from choroid, because there is a root that you form between the two places. That oxygenation counteracts the ischemia. The ischemia was causing dilatation of blood vessels and leakages from those blood vessels. So when you get oxygen from the choroid, that dilatation causes and reverses. You get 20% reduction in the caliber of blood vessels in that area, and that is how the fluid is absorbed and more leakage is stopped. So this is what's happening. It's from the science.
So maybe थोड़ा सा is for the pages,
of course.
people are doing it वो तो grid mechanisms देख के लगा देंगे. Problem है कि 50% of mechanisms spontaneous होते हैं, बनते और खत्म हो जाते हैं. So we should only be treating mechanisms which leak, and for that gold standard is FFA. For pages के लिए FFA के बगैर आपने मैकुला को हाथ नहीं लगाना, सिर्फ जो लीक कर रहे हैं उनको लगाएं. अगर आपने नॉर्मल को भी लगा देखा तो वो स्पॉन्टेनियसली रिप्रेस हो रहे हैं. So that is एक पॉइंट.
इतने बेसिक पे मैंने किया था, बल्कि एब्सोल्युटली राइट.
इम्पोर्टेंट थिंग, हम सारे पीजीज FFA आजकल कोई नहीं करता, सारे ओसीटी कराते हैं. FFA for macula is a gold standard. Still and only hit the leaking aneurysms, not the normal aneurysms. Aneurysms बनते हैं, खत्म हो जाते हैं. 50%
तो क्लिनिकली हम ये कह सकते हैं कि जिन एनेरिज्म्स के अराउंड एक्सीडेंट
वो भी नहीं पता है, वो भी नहीं पता है. Yes, they will also clear. और फिर दूसरा ग्रेड का जो मैं पुराने ज़माने का ब्रैकेट में बता रहा हूँ, ये पुराने बुक्स में लिखा था हाउ इट वर्क्स. तो अगर जब वो पूरी मॉडिफाइड ग्रेड से पहले पूरी ग्रेड लगाते थे तो रेटिना और डब्ल्यूटी का इतना मोटा हुआ था, आपको पता ही नहीं चलता था. सो यू आर एक्चुअली अप्लाइंग लेजर, वो जो मैट्रिक्स में ब्लाइंडली होपिंग के 10-15 मैग्नेटिज्म किसी ना किसी को हिट करेगा. ये जो थ्योरी थी ना कि क्लोराइड से आएगा, वो तो इतना थिक रेटिना होता था कि क्लोराइड तक तो लेजर जाता ही नहीं था. सो दे वुड जस्ट फायर ऑन द मैकुला. ये 100 में से 50 माइक्रोन उनको लग जाएगा, डीमा कम होगा, नजर आएगा, फिर दोबारा लगाना शुरू करेंगे. That was one of the
modified focal.
Yes. तो वो ही करते थे, they would just hit blindly. कुछ को लग जाएगा, कुछ को नहीं लगेगा, क्योंकि इतना मोटा रेटिना होता था कि कोरोना तक तो लेजर भी जा सकता.
और वो ब्लाइंडली अभी आपको मेरा मकसद ही यही था, इसलिए मैं FFA के पीछे नहीं.
like to add one more thing. Less from the boutique laser. when I left from the mechanism was that you just produce bleaching of the RP. RP को जब आप इंसर्ट देते हैं, there are two mechanisms. Either it will go into atrophy or it will go into hypertrophy. इसलिए दरमियान में हम उसको लेजर लगाएं, so they are replaced by more potent RP which are more able to form the fluid out of it.
These are all mechanisms proposed and because RP why doesn't get
As Dr. Qasim just said about FFA, you'll be surprised by doing FFA how somebody with a very normal looking eye, some visual problem, and you can't even pick up one microaneurysm there. And when you do FFA, it will reveal so much to you. So we can't ignore FFAs. Without FFAs, we can't move. OCT is excellent for follow-up, baseline and follow-up, so that you don't have to inject the dye over and over again. But to make a decision about even in AMD and diabetics, make a decision you have to have FFA.
And a further extension to what Tariq was saying, the idea was to produce a debridement of the retinal pigment epithelium. That was the exact word. You debride the retinal pigment epithelium.
आगे नया आपको
You have a new layer, but easier said. The concept is holistic one. All of the things that you said.
अभी थोड़ी सी आगे प्रेजेंटेशन आएंगी, जब वो माइक्रोपल्स के साथ कंपैरिजन होगा ना, तो वो फिर आपको एक पॉइंट क्लियर हो जाएगा. Anyway, we'll just go quickly on what we shouldn't do. These are very useful ones, and these are mostly from Pakistani patients. Some of them maybe not, but mostly they are. This kind of patient with very little vision, and you can't figure out what's happening, some little marks here and there. But only then, when you do the FFA, you see the real picture here, that this has been done to this patient in the name of a grade. So there's a lot of confusion in our country about grade especially. So a grade is usually, as we will see in Pascal, the grade is usually around this area only, whereas this area has been beautifully left or maybe destroyed, and PAP-MAC bundle is done. So these are the things we have to be careful about. We should know what we are doing, what kind of pattern we are following. And this is another favorite pattern of mine, because I see at least one such patient in 3 weeks on the average. And just to clarify this, we have beautifully shown on FFA that these microaneurysms and the main culprits have been beautifully left out.
Yes, beautifully.
Not done anything, and this is done.
Walling.
I'm sure we hope that this will also affect them also, because they are very close to phobia. तो ताकि हमारे वहाँ की गया इधर
तो इससे हमने किया क्या? इससे हमने इनको कुछ भी नहीं किया और हमने अच्छा सा रेटिना थोड़ा सा खराब कर दिया. So ये नहीं करना हमने, because this will not do anything to the patient anyway. सर्जन को शायद फायदा दे दे, लेकिन पेशेंट को कोई फायदा नहीं देगा. So it has to be targeted. It has to be either grade or this. But obviously, with this kind of patient, with so much mixture is going on, we will start with anti-VEGF and then we will do this.
Actual area is beautifully left. Actual area is beautifully left.
This is my favorite, that's why I said, because we see that a lot. Then, this is even worse than the last one. The last one did not do as much damage as this one did. Because again, the culprits were less, not so much, but this retina is good quality retina. We should be very careful about good quality retina. On here, we should just concentrate on the culprits and do targeted hitting. And at grade maybe if we are not sure, but only in that area. It should be FFA guided. It should be FFA guided.
तो इसके पीछे एक प्रोफेशनल और सोशल स्टिग्मा भी है. एक दौर था कि जब वो लोग जिनको लेजर्स प्रॉपर्ली करने नहीं आते, या अभी भी बहुत सारे हम में से भी होंगे बहुत सारे जिनको इतनी साइंस नहीं आती, तो क्या होता था कि आप देखते हैं कि लेजर में एक छटा सा लगा रहा है और बस छोड़ दिया. तो ये शायद उसने कॉम्पनसेट किया है, इससे वो उसने ओरिजिनल साइड को करने के अलावा और भी लगा दिया है ताकि अपने ज़मीन को सेटिस्फाई कर सके. कि मैंने 200-300 शॉट लगाए हैं।
लगाएंगे और आइंदा कभी नहीं होगा। तो यही है चीजें बस बट व्हेन आई स्टार्टेड सीइंग दीज थिंग्स, मतलब उसको ठीक की आपको बड़ी बेसिक चीजें बता रहा था। सो दे आर ऑल इन द बुक्स एंड यू फॉलो दीज एंड
ब्रिटिश के साइट बताते हैं अपर आर्म प्रॉब्लम हो गया
बिल्कुल। So
again भी फॉलो नहीं किया
again over here you can see we should try not to do so much fluid laser in the macular area because it will have more effect on the visual fields and your environment and everything. So this is another one. Now again we don't know what to call this one. Is it a grade, is it a PRP, or is it a focal, or a mixture of everything? Because if we are doing PRP, we should have a demarcation line here and stay out of that, away from the center. And if we want to do grade, it should be here. So all the dimness going from here to outside, that's an overkill. Now, no matter how hard or plaque-like the exudates are, but although we will treat them with anti-BPFs now, but in addition to that, it's a combination of a bit of laser. And this patient was only treated with laser, and as we can see, and even this kind of edema disappears at times. It's difficult, but it does. So saving the phobia, the central dump, as you can see, that not doing laser in the central and the central cleared as well, because it was dumping from the sides. Again, another example that just with laser and grid pattern laser in this area, and you can clear that area in time. Just different patterns, focal, grid, and although this grid is not perfect, this is too big a grid. This is why I actually am showing you this. Previously, there used to be a circle. A circle sometimes has to be done. But if you're doing the circle, be very careful with this area and try to avoid this rather than a circle being C here. So that is safer. And now coming to PRVs, obviously the aim is to preserve the central vision. And the aim of PRV is to do laser on the periphery, the ischemic areas, and keeping in mind the requirement of the patient. Some people have on FFA, you see this peripheral ischemia, it is too peripheral laser. But a youngish person, an angry-looking eye, or very angry-looking disease, sometimes requires 6,000 burns. And 6,000 burns should not be done in one sitting and should not be done in 10 sittings, but usually 2 or 3 sittings, because an eye can take about 2,000, sometimes 3,000 to 2,500 burns in one go. Other than that, more than that, you're more likely to cause macular tumors. And that's why we have to keep macula when we are doing PRP, and if there is something in the macula, people used to treat it with focal laser or macular laser first, and then few weeks down the line they used to do PRP. That is also fine, but nowadays, in an ischemic looking eye, it's not a bad idea to go into anti-BPF first and then start your treatment in a week or two, and you will have the same result. There are exceptions to this rule as well. In severe cases, sometimes you have to start macula and PRP together. And or if you get given anti-BPF and you think the patient will come back, that happens in our country, or very young patient with type 1, they are very aggressive as well. And so we do realize that with anti-BPFs, things have changed a lot. And I haven't gone in details, combination of all that, otherwise this topic will become too big. So the idea of PRP is to get rid of the new vessels and to avoid visual loss by PRDs and reassembly. So I won't go in settings and everything of this, but again the thing is that 2,000 to 3,000 sometimes is required initially for your treatment. If you have recurrences, what do? You do fill and PRP. Again something, nowadays you do anti-BPFs again and then you do fill and PRP. If that is not working, then obviously some part of the
I would like to add one thing. How to decide in how many sessions you are going to do PRP. What I do is I study the effect of the macular effect. Amount of edema, more the edema, more is the number of sessions. More the ischemia, more is the number of sessions. तो मैकुला को देख के डिसाइड इसको 2 में करना है, इसको 3 में करना है, इसको 4 में करना है. तो मैकुलर एरिया का इफेक्ट होने लगती है एंड फ्रॉम देयर यू डिसाइड कि इसको पीआरपी में कितने सेक्शन में करना है. तो मैकुलर एडिमा कितना है, more the edema, more the section. More the ischemia, more the section. So slow नहीं करते हैं. ये मैकुलर decompensation.
That's why it's important when you're ordering an FFA, mention to get some peripheral scabs as well, because otherwise you won't know how much ischemia is there. So combining the two,
Macular ischemia.
and macular ischemia and that. So macular ischemia again, they say they don't do laser in macular ischemia. If the ischemia is present over there, fine. If the ischemia is patchy, we should still go ahead and do it, because that patchy, obviously that particular part will not improve. But if you don't do that area, fluid can spread from that area. So we should still treat that area.
I divided macular area into 4 parts. And ischemia into 25, 50, 30, 100%. 100% जो पहले 50%. 25% then you can apply. 50% में you can tell problem. Sometimes prognosis is poor, but it's not a contraindicated problem.
100% don't.
नहीं तो सर उसमें जो है ओसीटी करवा के नहीं देखना चाहिए हमें फॉलोअप फॉलोअप के लिए.
जब आपका ट्रीटमेंट का डिसीजन हो गया, आपने फॉलोअप करके देखना है कि आपने कितना और करना है.
जी सर,
उसके लिए ओसीटी काम आता है.
इसी की बात है.
One is the vision,
हाँ.
another one is OCT.
Yes.
So sometimes OCT, आप अगर vision improve कर देते हैं, again you can hold your treatment.
ओके
So vision is also important.
ओके.
So if all that doesn't work, then obviously we have to go in to vitrectomy and laser and everything, and then most of the time, 99% of the time, the eye stent is done. The rules of doing PRP is we're forgetting about macular gray hair. We're just talking about PRP. The way we started, we should do a temporal demarcation line so that we know that this is the area we want to save. We should not go in there. So that demarcation line is there. Then, as soon as possible, it's best, also depending on the aggression of the disease, but if it's very aggressive, to go to the inferior retina first. It's very easy to do. The easiest to do is the superior retina. It's just sitting in front of you. Somehow the patient is sitting that way, and the lens are tilted by the brow and everything. Then it's easier to do the superior one. But it's best to do the inferior one in your first session as much as possible, because later on, if something happens, if any new vessels bleed or something, all that blood is going to settle down to the inferior part. It will not let you complete your PRP. So that should be done earlier in the process. And avoid the PAPMAC bundle and the macular area. And again, I'll show you in the photographs why we have to keep on saying that stay away from the disc. It is not essential to just touch the disc margin with your PRP. And the burn should not be very hot. And NPEs should not be touched laser directly, because then they'll contract and cause PRDs more than you need. And do not apply confluent burn, should be one burn apart. And the opposite thing of what we often see periphery not being done. Periphery is the one which has to be done, with more vigorously, and they should be closer and more burn in the periphery, because that is the most ischemic area, and that can only be done by wide field lens or maybe triple laser at time. So wide field lens of any kind is very important with the lasers. So this is just the importance of the laser. The time is less, so I'll just go quickly. Again, just to show that PDR is there just by doing PRP. PDR is gone. NVDs are gone. Then this just by doing laser is cleaned up. So, and now what are the don'ts? Again, this is the one where you see that very nicely done. Again, we see that very often around the posterior pole, around the arcade. This get laser done, and the periphery is empty. And maybe people do not have wide angle lenses. That is the reason, I don't know, but we see that a lot of times, laser done here and then nothing here. And again over here, this is what you were saying, that people want to do laser and justify themselves. So this is that justifiable laser done here, no pattern. Again, we should be careful not to be too hot, because eventually these can cause neovascularization as well and cause problem and will worsen the central retina. Now, as we do confluent laser and very hot laser, we should realize that we can eventually cause optic disc-pallor. So, unless there are certain circumstances which we'll see in a second, where confluent laser is required, or when we do too much fill-in, it becomes confluent. But like aggressive diseases like this, sometimes you have to do this. But in a situation like this, what's missing here? Anybody would like to do something more here? So you see a lot of PRD here. Laser done here. Laser is complete, actually more than required, but it's quite complete. But in a situation like this, I tend to ask Tariq here as well, give his comment that a little barrage, a very gentle barrage should be done here as well. Because no matter how quietly we done in this area, this will contract and cause some problem in the central area. So a little gentle barrage sometimes preserves the shape of the retina in that area. Would you agree?
वैसे कि जो ट्रैक्शन से थोड़ा दूर है, थोड़ा सा दूर,
Directly in,
डायरेक्टली line between the
Cut.
fovea and the macular areas.
Sometimes the laser itself can shortage of those. So you have OCT and see if it is required or not. If it is stable or not. If it is stable, then it is not leaking. If it is not stable, because sometimes the PRP can actually lose that type of solution.
So if you do directly. So in a situation like this, obviously a very aggressive one. Again, the problem is this is almost nicely done laser, but nothing done in the periphery. So when we are dealing with this, the problem is here, and that ischemia is causing all this. So for LVE, so when we are doing this, or when we are doing this, this should be completed. This should be done, not to concentrate on this thing. And in these lasers, here is a situation. The new vessels can be this aggressive, and here is a situation where confluent laser is justified and it quite easily eyes down. Otherwise, it will be more bread and butter for the VR surgeon. Fine, it's a beautiful looking eye, membrane is taken off, and you get very good results, but it doesn't happen in everyone. Most patients do not, they are not as lucky as this one. So it should be done in time, earlier in the process, so that we don't have problems. So these are examples of some lasers. I'll just go quickly, don't want to waste time here. Lasers for CSR. So CSR you can do laser, won't go in detail, you know that you should wait 6 weeks and this and that, whatever, because that's area of CSR. I'm just talking about laser here, that you look for the hotspot, obviously with FFA. And with FFA, you see if there is a hotspot, you require about 3 to 4 burns of light to medium intensity. And again, do maybe one here where you see a very light intensity one, and then come closer and do this. And on the edges of the CSR, and it does the trick with lots of other treatment modalities, you know, all the medications and Kepler and all those with the treatment, but this is the laser. Then we have the barrage. Again, this is a fashion here, or I've even seen some studies, local studies, which they were about patients where they were just doing the posterior edge of the braids. I don't understand why that was being done. Why was the interior edge left? So never leave the interior edge, because we have often seen laser done here and seeping from here and then causing a detachment. That will happen. Why will it not happen? So it's important to do all around. They should be very confluent, or you can use paint mode if you have it on your laser. Similarly, if you're doing 360 for lattices and other disease processes, you can do interrupted one or you can do paint mode, but never the anterior aspect as much as possible. I know some of these are very difficult to do, and if they are very risky breaks or such things, and you can't do anteriorly, take the patient to theatre and do a bit of ground because it has to be covered.
Indirect laser.
Or do indirect laser with indentation. Now, then CNVs. Again, lasers were very common for CNVs before the anti-BPS. And now it's very seldom that we do that. And I remember, even in Pakistan before 2005, I had 2 years, 1 or 2 years here before Iraqi. And there are a lot of CNVs here. And the only thing is that it has to be away from the phobia, because when you do a CNV, it has to be very high power burn, 600 to 800, and it has to be wide reaction and longer duration, at least 500 milliseconds, and you have to extend half a burn with outside that. So that should still be away from the phobia. And sometimes it can cause puckering. It can cause puckering. I will not say that it's 100% safe. But still, if you're careful and all, most of them work well. Again, nowadays we use injections, but that is an option if you have something away. I'm going to actually do in one of my patients, maybe this Saturday, or next Saturday, because I don't know, dozens of injections and they keep coming back. And there are 3 of them. So at least 2 of them I can burn, so I will do that. Now, in Coats disease, we have to burn the vessel directly by confluent long, again, same settings as CNV almost, and we should see the vessels shrinking right in front of us. But we have to be careful. We look back in about 5 minutes, and those vessels have opened up again. So we have to repeat the laser, and usually these are Coats ones, they are kids or they're young people. You have to do it under general anesthesia mostly, and you close them down. If it's partial Coats, then you do a barrage laser as well. ROP. Now in ROP, the most important thing is whoever wants to start it should start doing indirect laser first. Indirect laser for patients like CRVO and other things, lie them down and do indirect laser, and then that's how you get to practice. And then eventually when you're sure how you're moving your hand dynamically while doing the laser, then you can go ahead and do the dome. The only difference is that they should be very confluent. And this is my favorite on my list. Took this photograph when we were doing laser. And so yellow is the best one, but green is fine for this one, and should be done under general anesthesia. It has to be wider reaction, it has to be very confluent, and the whole ischemic area has to be covered. Most important thing is, now there is a controversy, and Umar comes here often, and I always talk to him about this, and he's now agreeing slowly that we should do this. They used to stay outside the ridge. There should be 1 or 2 rows behind the ridge, because when you stay outside the ridge, you quieten the disease down, but a little bit of traction will affect the macula, and those 2 lines will protect the macula and for future. The other thing is, even these are not enough. There are too many gaps in this. For ROP, there should not be any gap. Third thing, you see often behind the ridge, these are the vessels. So you have to go in between the vessels. So in this one, this laser is done now. I would have gone even here, this way, because otherwise they do shrink and they cause problems. And there is a confusion arising now about ROVs. We don't know if this will be proven or not, that they are changing the whole thing in ROV, that maybe it is not. One thing is right, no matter how ischemic the ROV is, we seldom see NPDs, and we seldom see rubiosis iris. But I have seen rubiosis. They claim that they haven't seen any. I've seen rubiosis in those as well, but it's very, very uncommon. So obviously there is something else going on. Now they call it misretinalization, and they say the pathology is at the interface of that immature vitreous and the immature ILM. And they say it's not typical one. And so what they are doing is they are doing 6 rows of laser around the edge, the ridge, and leaving the interior ischemic gray retina. But we have to be very careful about that. It's not supported by a lot of other things. Okay, now again, this is a more thing not done now, chorioretinal anastomosis. So we just leave that because time is short now. This is Pascal. Pascal has many treatment patterns. You can have squares, arcs, circles, whatever. And just go quickly here. You can see Pascal versus manual laser, and you can see the kind of grade the Pascal does. And this is a big grade actually. And the difference here, you can see that Pascal can be done on blood vessels as well. It will not affect your blood vessels because it's deeper and gentler and everything, as opposed to the other one where blood vessels should be saved. So that's another advantage of this. It's much less painful. You do an OCT, you have a fluid map here, you put a map on the machine and you design a grid pattern here, and you do that and you can get it in fluid. So that's another, it will be customized. This is to show you the difference between normal burns and the Pascal one. In normal burns, retinal nerve fiber layer is disrupted and all the tissues are burned. In this one, the nerve fiber layer is preserved and it's much gentler, less inflammatory response. So that's why the visual results are supposed to be better in Pascal than the other ones. Now, again, different patterns. This is showing you the grid area, not the big one. This is a big grid as well, modified grid. Now, this is a typical grid area. So rather than this involving this area, this is the art. Just show you quickly. I'm nearing finishing now. So this is the Pascal being done, and you can see that you need a little bit of practice, and once you have the practice, you come very fast. This is the real beauty of this, applying a grid laser like this in an automated fashion. And these are the peripheral ones you are doing. It can be done in peripheral scatter as well as garages. So this is being done now. Now, finally, coming to the end, the micropulse laser. This may change our practice altogether. Let's see, in the next year or so, we'll find out. It went on for a few years. It's a tissue sparing solution, and it's also being used for glaucoma as well. And the glaucoma machine is here in Pakistan. It's being tried in different areas. They say relatively good results. I need to follow that up. And but the difference is in a continuous mode laser goes up, it stays like this and then goes down. In this one, you have duty cycles. So within that same period, it has not done this much irradiance. It has done this lines of irradiance and so much time in between to let tissue cool down. So what we say the duty cycle is, if that is 100%, this one is 10 to 15%. So even 5, 10, 15%, and that is recommended. And so this is the machine for retina. This is the model. These are the glaucoma ones, and I'm hoping that we should get it soon. This is the difference between a green laser, usual laser burn, where the central cells are dead, and this is the area which is just therapeutic, like I just mentioned as well, and Kasim as well. That area, you just have therapeutic effect. You don't destroy that area. In micropulse, this is all you get. You don't have any destruction of tissue. You only have activation of tissue. Again, small burn, high burn, but usual laser, central dead area, then therapeutic area. Here you can do confluent laser, and you will have therapeutic effect everywhere. Now, you have to be careful. We have to see few years down the line as well, what they have done 2 years ago, how are the tissues, but for 2-3 years follow-up, it's a good result. As you can see, it's brilliant for CSR. It is the treatment for CSR. You don't have to spare the phobia. There's a good macula. You just do that here and get rid of the CSR. Again, in vein occlusions and problems like that, you do this area, it's gone. Again, FFA proven vein occlusion leak, and you just do it here and it's gone. So it's a very safe one. You have to be patient. It takes time to work again 3 to 4 months because the tissue is absorbing fluid there. And here the bonding is opposite. Do not undertreat, because if you undertreat, then you will not have results. So it's best overtreat a little bit. Patient will have no discomfort, and you treat bigger than the area involved and treat confluently. So that is the thing about this micropulse laser, and you will have better results. It is also showing results somehow in retinitis pigmentosa patients because it stimulates the tissue. So if you do the periphery, I'm going to do more slides there. It stimulates the tissue in the periphery. They've done that, and it starts working better without any destruction. So more work has to be actually followed up on this one, but these are the ones. So basically, lasers are beautiful and they are wonderful tools to help the retina, but you have to keep in mind that they are deadly as well, they can be harmful as well, and you should get a full knowledge and all the test criteria sorted out first, and decide on the laser pattern, and then obviously you will have good results. Thank you.
Thank you, sir.
Next one, question.
Sir, I have a question. So whether we're using Pascal or the micropulse, question is going to get visual field effect in the area of laser or not?
In the micropulse, no.
There will be no visual field effect.
In Pascal, you will have some, but less than
Less than green one.
But
So ideally, you should all do Pascal if you want to save the visual field.
as compared to normal one, Pascal is better.
And then micropulse.
Micropulse, I mean, it's a new thing, but it's very promising. Very promising.
So the side effects of PRP like night vision problems, they'll go with micropulse. But there will be no visual field effect.
The thing is, micropulse is usually for macula. It's in retinitis pigmentosa, it's used not to destroy the tissue, but to save tissue. In PRPs, you want to destroy tissue. So they haven't come up with results on PRP, and it may not be for PRP, or they may come up with a totally different theory that okay, it has improved oxygenation of that area as well, and it is better. So, but we don't know. So I do not have any comments on PRP for micropulse.
PRP just for
Or retinitis.
Any other question, comment, or
Sir, thank you very much for telling us the significance of this macular geography. I just want to ask this you can see OCTA, whether we can think about doing it more in the future, or we should still be very much pro conventional fundus fluorescein in geography.
Fundus fluorescein in geography will not pick up those things which ICT in geography will pick up. And this will pick up a lot of those which you pick up in ICT.
वो 68 मैं वही कह रहा हूँ 22% दोनों
मैं वही कह रहा हूँ कि FFA वो चीजें नहीं पकड़ेगी जो ICTA पकड़ेगी, और ICTA जो पकड़ेगी वो OCTA को बहुत सारे पकड़ेगी।